Good afternoon, ladies and gentlemen, dear colleagues, and welcome to ESC Asia. This evening we are focusing on something that has been at the forefront of our minds for many months now, and that is COVID-19. And it's nice to think about it now that we're starting to see a bit of a light on the horizon of this big problem. So tonight what we are going to have is two excellent speakers who are going to give us both the Asian Pacific perspective, and that will be Professor Yeo from Singapore, and the European perspective, and that will be Professor Martin Landray from the University of Oxford. So without further ado, I think we should focus on the presentation, and Professor Yeo, please start your presentation.
Thank you very much, Professor Casadei. It's a real pleasure to be here at ESC Asia 2020. You know, this is a difficult time for all of us here in medicine and frankly for all of us in the world. COVID-19 is a pandemic that is once in a century and has hit us like a storm. So in Asia, we do have our share of how do you call it, successes and failures. And allow me to share a little bit about COVID-19 and cardiovascular diseases. These are my disclosures, none relevant for this talk. So the mechanism for myocardial injury in COVID-19 is not entirely clear. We do know that there are multiple types of mechanisms, and in this talk, I'm going to talk about these mechanisms as well as the presence of COVID-19 as a cardiovascular risk factor for death, and the presence of prior disease, as well as troponin elevations as markers. We're going to talk about the long-term cardiovascular complications, effects of disease presentation on work volume, as well as how they are presenting to our hospitals and what the experience in Asia and key public health measures have been in this part of the world. In preparing for this talk, I've referenced the ESC guidance for the diagnosis and management of cardiovascular disease during the COVID-19 pandemic, as well as a reference from circulation heart failure, which I thought was very useful in shaping how I thought about this particular problem. These are some of the reported mechanisms for myocardial injury or myocardial manifestations in the setting of COVID-19. First, there is the type 2 myocardial infarction, what the typical oxygen supply and demand mismatch. Patients with COVID-19 can have acute STEMI from thromboembolic presentations. There is also the hyperadrenergic state. There's the presence of microembolic infarcts, a pro-inflammatory state with a cytokine storm, direct viral invasion, autoimmune response, and interaction with extraepicardial tissue, extraepicardial adipose tissue. Then there is also the probability of developing ischemic cardiomyopathy, non-ischemic cardiomyopathy, systolic and diastolic dysfunction, arrhythmias, and atrial fibrillation. Moving to the next slide. This particular slide shows some of the early studies on acute coronary injury in patients across various reports with the COVID-19. You can see that across these various reports arising from different parts of the world, in China, in the United States, that troponin elevation is reported in anything from 4.5% to 41% of these patients. And in various reports, there is evidence of myocardial injury as well. The cardiovascular implications of COVID-19 in this small series, in this 3 studies, suggest that the elevation in troponin can be between 12 to about 30%. And this suggests that then these studies show that up to 33% will die from respiratory and circulatory failure and 7% from myocardial damage and heart failure. In this particular study, again out of China, this looked at the effects of underlying cardiovascular disease on COVID-19 patients. This is a single center study from the epicenter of the pandemic in Wuhan city and out of China across approximately a 1-month period in 187 patients. You can see from this particular study that if I go to my next slide, that the comorbidities that were present in those with troponin elevation and those without were markedly different. In those with troponin elevation, there was a greater preponderance of comorbidities, including hypertension, prior history of coronary heart disease, cardiomyopathy, diabetes, and COPD. So these suggest that patients with troponin elevation were more likely to have prior significant comorbidities. Now, if you look at this slide in terms of the complications or the adverse outcomes associated with COVID-19, those with, say, VTVF or death were more likely to be present in those with elevated troponin levels. This slide summarizes it very nicely. If you look at the 4 lines here, those with prior cardiovascular disease and elevated troponins had the highest mortality compared those at the bottom line, which were those with neither cardiovascular disease nor abnormal troponins. And of course, in between, those with elevated troponins were the second worst out of the 4 categories of patients. There is a more recent publication looking at the prior history of heart failure, and if you look at this particular study out of the US, if you look at, I believe this was from one of the hospitals at the Mount Sinai Network, looking at 6,000 over patients admitted for COVID between, I think, approximately 4 months in 2020. A history of heart failure was associated with a high risk of mechanical ventilation and mortality among patients hospitalized for COVID, regardless of the LV function. So this is, I think, an important finding that we should bear in mind. What about recovery from COVID? What happens after that? Well, this is an interesting study looking at the outcomes with cardiac MRI in patients who have recovered from COVID-19. This is a prospective observational cohort study looking at 100 recovered COVID patients out of Frankfurt. These were compared with the age match and sex match, the control group of both healthy volunteers and those who had risk factors matched. And the patients had cardiac MRI performed after symptom resolution and a negative swab test. Essentially, if you look at these 3 categories of patients, this column here with the COVID-19 had the highest percentage of late gadolinium enhancement across those with myocardial, pericardial, and non-ischemic categories. The healthy controls had none, and those who had risk factor match had modest elevations as well. And of course, all these were statistically significant. The median duration between the positive COVID-19 testing and the cardiac MRI was 71 days, and 12 patients of these had an ischemic type pattern on myocardial late gadolinium enhancement. 3 patients had severe abnormalities with subsequent biopsy showing active lymphocytic inflammation with no evidence of the viral genome. Overall, the cardiac involvement was seen in 78% of patients, with ongoing myocardial inflammation seen in 60% of patients. And this suggests that ongoing perimyocarditis can occur after COVID-19 infection after what appeared to be overt recovery. So arising from this paper and others, this Heart Rhythm Society paper proposed that in patients who were recovering from COVID should continue to have cardiac evaluation, and some of the suggested imaging modalities included echo with strain and late gadolinium MRI scan. So I think the jury as to exactly what we need to do for post-COVID infection patients, and this has of course long-term public health considerations. Now, I want to move on to the impact of COVID on some of the services we provide in cardiology. This is a very nice paper that came out, I think, fairly recently, if I'm not mistaken, just a couple of weeks ago, looking at European high-volume primary PCI centers and looking at the numbers of STEMI treated with primary PCI between the same periods of time in 2019 and 2020. And you can see that in this particular study, there was a significant impact on the treatment of patients with STEMI, with a 19% reduction in primary PCI procedures. It is suggested that a longer delay to treatment may have contributed to the increased mortality during the pandemic. This summary slide shows what I just mentioned. If you look at the number of primary PCI per million residents over this same period of the year, there is a statistically significant decrease. And if you look at the total ischemia time, total door to balloon time, in-hospital mortality, as well as in-hospital mortality that's adjusted, you will see that all these were statistically significant across the two periods of time. In the editorial, the authors reported that these were some of the possibilities as to why this may have been the case. First, due to the fear of COVID exposure, fear of being a burden to the medical service, reduction in the number of healthcare workers available, issues with classification of patients at COVID risk, the use of PPE, and getting access to a negative pressure cath lab all causes delay and will affect the mortality and complications for STEMI. I'm just going to quickly talk a little bit about some of our own local experience. This is National Heart Centre Singapore's numbers before and after the institution of the circuit breaker. You can see that all AMI, there was a statistically significant decrease, but for STEMI, the numbers were perhaps more, although there were numerical decrease, there were not that much difference. The main changes were in the non-STEMIs. And if you look at the primary PCI rates, they fortunately appear fairly flat despite the presence of the circuit breaker. So this is somewhat reassuring to all of us. I want to now jump into some of the public health measures that have come across that we have instituted here in Asia. And this is quite a nice study, or rather nice data from the Center of Strategic International Studies, which show that depending on which part of the world you are in, and even the country, there's been there are significant differences in the number of cases, number of deaths recovered, as well as a case per million. We have a very high case load per million population, but our number of deaths have been fortunately low at 28, despite the number of the number of cases we've had. And I think I just wanted to put this slide up to show that this has a very variable impact across the world. Again, a similar slide showing the mortality rate by country in Southeast Asia. And I think coming to the end of my talk, I want to just talk a bit about some of the key public health measures that perhaps are good for us to all share and learn from each other. We learned a lot in Singapore from the early Chinese experience. One of the key messages was to isolate the infected, and this included removing them from the family because of a great deal of within family transmission. We quarantined those at risk early on. There was aggressive contact tracing, and we identified differential risk in infected patients. Those who were at highest risk were kept in hospitals, and those who were at lowest risk were sent to community facilities, and we used technology aggressively. This health policy paper, I will just talk a little bit, published in The Lancet, talked a little bit about some of the various measures such as safe physical distancing. Depending on the part of the world that you're in, it can be 1 meter to 2 meters. The practice of mask wearing, say in Korea and in Japan, these was widespread and mandated during COVID-19. And of course, some countries in the world continue not to have a mask wearing. And coming to the last slide, I think this is actually quite important. You can see that depending on the country you're in, there have been various public health contact tracing tools. In Singapore, we do have, I think, almost all of these: telephone, computer, QR codes, cell phones, wireless, CCTVs, Bluetooth. And interestingly, in Korea, they also do use the credit card transactions to help track patients. So I want to end my talk with this summary slide that patients with existing cardiovascular disease and evidence of myocardial injury as evidenced by troponin elevations in COVID-19 have worse in-hospital outcomes. Number two, COVID-19 is associated with myocardial involvement months after the infection has cleared. Number three, it is reassuring from local data that we do not have more heart attacks, but the long-term effects remain unknown. There is definitely some impact on services due to a variety of factors, as shown in the study out of out of Europe. I want to also say that there is a diverse experience in Asia in terms of the spread of the pandemic, and that public health measures remain critical for the COVID-19 pandemic. With that, thank you very much.
Thank you so much for this excellent overview of the situation in Asia. Now we're moving to Europe and see how badly or how good we have done. Martin.
Thank you very much, and a great pleasure to be here. So I thought I'd give you a perspective, it's really an epidemiological perspective, and the epidemiology comprises two parts. One is, if you like, how bad the epidemic has been, and particularly the impact on patients with cardiovascular disease. Second, what should we do about it, and how do we find treatments that will actually get us out of this situation? So my funding and interests are listed on here. Just to highlight the ones at the bottom, which are the commercial support, Roche, AbbVie and Regeneron have each given the NHS, the National Health Service in the UK, supplies of treatment specifically for use, exclusively for use within a clinical trial, the recovery trial, which I run. So I'm going to divide my talk into two parts, if you like. One is the impact of COVID-19 on hospital admissions, and even that is going to be in two pieces: hospital admissions for COVID-19 and hospital admissions for acute coronary syndrome. And then I'll turn to the need for reliable evidence about which treatments are actually effective. So this pair of graphs is taken from a couple of weeks ago. Sadly, the picture is even worse now. These are UK data. You see very similar patterns, of course, in other parts of Europe, perhaps by 1 or 2 months. But by and large, we're seeing similar patterns. But I want to particularly focus your attention to the situation in very early March, when the epidemic was in full swing, sadly, in northern Italy, but had yet to really spread to the UK. And at that point, we could already imagine that the health service was going to become overstretched. We'd been hearing that from Italy, that there would be huge time pressures and personal stress for the frontline medical staff. And of course, there would be very large numbers of unwell, anxious, elderly, and alone patients. And so that there are stresses on the system in all regards. Now, in the UK, as I say, the warnings that the epidemic was coming were really gathering in volume and profile in late February and very early March. It wasn't actually till the 23rd of March that the UK government called a national lockdown, and it was a fairly complete national lockdown at that point. But what we're looking at on these slides is the number of hospital admissions for, on the left, acute coronary syndrome, and on the right, acute myocardial infarction over that period of time. So on the very far left, you can see the 2019 average. So for acute coronary syndromes, every week there's about 3,000 patients admitted with acute coronary syndrome. In the week following the introduction of the national lockdown, that number was 1,800, a 40% reduction in the number of patients presenting with acute coronary syndrome. And you can see similar size reductions in the number of patients presenting with acute myocardial infarction. But what I want you to really note from that is that actually the patients were ahead of the government, and that it was actually largely the patients not presenting to hospital, even in the weeks before the lockdown arose, rather than the hospitals being overburdened per se. So it was almost the fear of the epidemic and the public message, please, your hospitals are going to be so busy dealing with COVID, please don't bother them with other things, that actually had this unfortunate negative consequence on presentations with acute cardiovascular emergencies. So how did the hospitals fare? Well, in here, what we can see is the in the black lines, the number of admissions, the absolute number of admissions, and you can see that for both ST elevation MI and for non-ST elevation MI, that there was a reduction, perhaps slightly more pronounced for the non-ST elevation in those number of procedures performed. But in the blue line, what you can actually see is that of all the cases that presented, the proportion that were getting acute coronary intervention remained stable or even went slightly up. So this wasn't actually an issue with capacity to deliver effective and proven treatments within the hospital. Again, this reflects the public health messaging, please stay away from your hospital, which is fine if what you're staying away from is a condition that can wait a few weeks. But for acute coronary syndrome, that's clearly not the case. So as a cardiovascular doctor, clinical trialist, epidemiologist for the last 20 or more years, why did I suddenly decide that I would drop everything else I was doing and start and look at trials for treatments for COVID? Well, one is that this was clearly a public health disaster. And the second was, it seemed to me that the world of COVID had an awful lot to learn from the world of cardiology. So we need randomized evidence. To put this in context, for patients who come into hospital, then the mortality is around 1 in 4 patients. So 1 in 4 patients admitted to a UK hospital, particularly during the first wave of the epidemic, would die during that hospital stay. For patients on ventilators, that number went up to 1 in 3, or even in some cases, 1 in 2 patients would then die. There's huge uncertainty about how to treat those patients. There are literally hundreds of candidate drugs. There are many, many opinions, some of them very high profile, some of them informed, rarely the two together. But there is frankly no reliable data. Uncontrolled case series, inconclusive, small randomized studies. The European Medicines Agency and the WHO each put out a call saying we do not need hundreds of small randomized trials and observational studies. We need 1 or 2 large randomized trials with a control group, which will actually tell us which treatments work and which ones do not. And that reminded me very much of cardiology in the 1980s when I was actually a medical student. And so if we go back to 1984, we can see this paper from Salim Yusuf, Rory Collins and Richard Peto, pictured on the right a couple of years ago with the late Professor Peter Slight. That they wrote this paper, why do we need some large, simple randomized trials? Not making the point that every trial needs to be large or simple, but that we certainly need some that really focus on the things that matter, mortality. And what's really interesting is if you reread this paper, as I did back at the beginning of March, and replace the phrase myocardial infarction with COVID-19, it's remarkable how much else just slots into place. And of course, it was that same group that demonstrated the success of that approach through the ISIS-2 trial. A single, simple case report form on the left, compelling results on all-cause mortality on the right. But what I thought was really interesting was this paragraph taken from the bottom of the front page of the protocol. By far the most important determinant of the success of the study is the extent to which the responsible physicians and nurses choose to enter their patients. Hence, the extra work must be and is absolutely minimal. Now, given the burden of COVID, that seemed like a good philosophy as we went forward. And so we established on the 9th and 10th of March this year the recovery trial. We wrote the protocol. I had the ISIS-2 protocol on my desk as I did so. We wrote the protocol on the 9th and 10th of March. On the 19th of March, we randomized the first patient. Yesterday, we passed 17,500 patients. Simple eligibility, important outcome, randomization between a range of different treatments that might be suitable for that patient, and then follow up actually with a case report form and then using the modern digital world, linking into health records too. We've studied antiviral treatments, hydroxychloroquine, lopinavir. We've studied immune treatments, dexamethasone, azithromycin, tocilizumab, some targeted anti-SARS-CoV-2 treatments, so targeted at this virus, convalescent plasma, neutralizing antibodies. And actually just in the last week, we've added in a randomization for aspirin versus control to try and understand whether antiplatelet treatment might also reduce some of the complications. And it's remarkable what a whole nation effort can be. On the left, a map of the UK, every single acute hospital in the country has enrolled patients into this clinical trial, about 176 different hospitals in total. On the right, you can see the speed of recruitment. So as I say, from the first patient on the 19th of March. We've had 10,000 patients 8 weeks later, 12,000 patients within the first 100 days. We then had a lull over the summer when thankfully COVID went into remission, if you like, but we have seen a very definite resurgence this autumn, so that we're now back to the levels that we were in April. And you get compelling results. A simple design, large-scale eligibility, large-scale enrollment, and eligibility really was open to anyone, any age. Youngest patient was less than 6 months. The oldest was over 102 years. People from all sorts of ethnic and other backgrounds. About 20% had prior cardiovascular disease, another 20% had diabetes, and so on and so forth. So here are our first two results: hydroxychloroquine and lopinavir. Lopinavir is an HIV treatment. So we tested each of these separately. Both have been highly recommended in all the national guidelines around the world, widely recommended, widely promoted, and completely useless in patients who've been admitted to hospital with COVID. That changed practice. These are no longer recommended and no longer used. By contrast, dexamethasone, which in fact in those same guidelines have by and large been marked as contraindicated or not recommended, we saw in June this year, we were able to announce very, very clear beneficial results, such that dexamethasone 6 milligrams once a day for up to 10 days reduced the risk of dying from any cause by about 1/3 among patients on ventilators and about 1/5 for patients who had less severe disease but still required oxygen. And that result changed practice and changed policy overnight. In fact, actually not even overnight. We announced the results on lunchtime on June the 16th. At that tea time, the chief medical officers in the UK had written to every hospital saying this should now be standard of care. So really a case where you announce a result at lunchtime, you implement practice at tea time, and you save lives by the weekend. And that's been taken up all around the world over the subsequent weeks, and is undoubtedly saving tens of thousands of lives around the world because of the clear evidence that came from the randomized trials. This is not guesswork. This is not speculation. This is knowledge. And so finally, what can we learn as cardiologists from this experience? Well, many of the things we sort of knew already, but by and large had tended to ignore or forget. Arbitrary use of unproven treatments really should be avoided. That large randomized trials are actually a critical component of clinical care. It's not that that one group of doctors do clinical care and another do clinical trials. They are the same thing. That clinical trials, randomized evidence, need to be brought back to the bedside, back to the patients. And that compelling results change practice, just as the ISIS-2 trials changed the management of acute myocardial infarction overnight in the late 1980s. But to make this work, trials have to be feasible, they have to be inclusive, and they have to be focused on outcomes that matter to patients and matter to public health, as opposed to matter for any other nuanced reason. So as I say, what we've really learned from this is not only that we can use the lessons of the 1980s cardiovascular trials in order to identify which treatments do and don't save lives in COVID, but that we can use that same philosophy and that same knowledge as we return to our day jobs over the coming year and look for treatments for cardiovascular disease as we move forward. Thanks very much.
Thank you very, very much, Martin, for this, shining some hope into the situation. And that is really where I would like to focus the discussion. So we're starting to see the way out of this, I think, or at least my optimism, I think we're starting to see the way out of it. We have potentially 3 vaccines and we have the ability to do mass testing. So what do you think, KK, for instance, in Asia, would be the most important things at this point in time to restart going back to normal, taking into consideration that maybe the vaccine will take some time to deploy?
Well, I think that's a difficult question because, with this pandemic, it is not just about the medical parts of care, but also the economic aspects, and I think not surprisingly the geopolitical effects as well. But if we were to focus on the medical and the economic aspects, I think one of Asia's strengths and weaknesses is that it is very, very disparate in terms of access to care, access to technology, as well as social acceptance of some of the restrictions on personal freedoms. So I think we can see from various parts of the Asia Pacific that that the willingness to be restricted in terms of personal freedoms and wearing of masks and hand washing and other restrictions have brought down, have flattened the curve, say, in a country like Singapore. But in other parts of Asia, it has been a bit less successful. And I think that's always a challenge. So I think before we get any norm back, Asia being a very connected, as with many parts of the world, it'd be quite a while because even if we wanted to open borders, it's going to be difficult. Now we have been fortunate in Singapore, and I must say that we don't take this lightly. That we have been able to start some travel bubbles with other countries, and Hong Kong is one example. But I think it'll be a while before we can have free, unfettered travel across different countries within Asia.
Yeah, thank you very much. What do you think, Martin, would make a difference in Europe in the short, medium, and long term?
Well, I think we have to look at this in sort of four components, if you like. I sort of liken it to how you manage reduce deaths from household fire. Clearly, the first is our own behaviours. So this is not something that we rely on other people to do, but in terms of social distancing, in face masks, keeping outdoors rather than indoors, those are things that each of us can do. We don't rely on somebody else. The second thing is in terms of prevention, and there clearly the vaccines are really excellent news. The third is around detection, and again, having effective testing and tracing will make a difference. It does make a difference in the places where that works, and in many places it's still not working. And the final is that when your house is on fire or when your relative actually has COVID, you want somebody to put out the fire or treat the COVID, and that relies on treatment. But the underlying message of all that is there are things that we can do, and there are things that require the system and coordination to do. But that's what we've come from, particularly around treatment, has been a situation where large numbers of drugs are thrown at large numbers of patients with no knowledge or hope of gaining the knowledge about whether they work or not. We're now moving to a situation where increasingly we are getting that knowledge because trials are at last getting done. But knowing that a treatment is beneficial and having it as a solution to the problem are two different things. And we have to work on fair and equitable and affordable access. And that's not simple. It requires production, it requires distribution, and it requires some pretty serious thinking about how the finances of that are going to work. That's crucial to understand how we're going to be able to actually deliver treatments, deliver vaccines, even deliver testing on the scale that's needed. This is not a rare disease. This is a whole world problem. It's a major public health problem, and one has to look up and see that big picture.
Is this the thing that worries you most? The ability to scale up our interventions? I mean, what is it that we should all focus our minds, because it is the thing that is most needed and most difficult to achieve at this point?
Yeah, I think that all specialists, and I count ourselves as medical specialists, and technical specialists, we tend to focus on, can we find a technical solution? Can we discover something? Can we discover a vaccine, discover a treatment, discover a new testing kit or whatever? But one has to think that this is that's not enough. One has to think about how does one get the large scale delivery, and that's a very, very different problem. This is not a question about how do I get my new drug past the FDA or the European Medicines Agency so that it's licensed and I can sell it. This is a question of how do I actually get it to very large numbers of people so that it actually solves the problem we really have.
Yeah, so Dr. Yeo, this is your last word to you. I mean, Asia is very organized and in logistics and structure, much more than Europe. Do you think you're going to win this battle because of that?
Well, to be honest, I think nobody is winning the battle right now because it is really too early to say. I think for those of us who starts counting the eggs or the chicken before the eggs hatch is in for trouble. We don't know how long these vaccines last. We do not know for sure what the risk of reinfection would be. We don't even know whether or not we can get the disease under control across the oceans. So I think it'll be quite a while before we can be sure that there is victory. And I think just to reinforce the notion that Asia is disparate, I think there are parts of Asia, especially in South Asia, where the disease is still not quite under control, and even in a place like Singapore, or I read reports that even in say Korea or Japan, there are cases that have recurred and not recurred, but there's been spikes, and there's always a cause of concern. I think the battle is far from over. The war is far from won, and I think we all of us have to dig in deep and be very. This disease can come back and bite us, and I think we should be prepared to last for a couple of years with this particular war. And I think as Martin and yourself, Barbara, have alluded to, I think this requires a whole of society response, because there'll be social economic impact. There will be fake news, and there all these things are, I think, part of what we need to do.
Yes, no, I think that all national cardiac societies, all professionals, and all professional societies like the European Society of Cardiology have a duty really to follow the situation very closely and be instrumental in conveying truthful information and useful information. And that's what we are really focused on also at the level of national cardiac societies. So, if I have to sort of conclude, I like to be optimistic. I see a way out, and I see how important is also our collaboration with biotech and industry. We academics may come up with the idea of a vaccine. We will never be able to scale it up to the level that is required. And so I think I want to reinforce that it's important that academics and professionals and doctors work with industry in the right way. When there is a problem, to join all the efforts together, I think is really important to do that. I take the point also that we are very diverse in our geography, in our communities, in our governments, and that it will be difficult to move as a united front with the same. But, we will learn from each other. And I think that is also a good point. We must learn from each other, something that hasn't happened in Europe at the beginning. Has been much more effective in Asia, actually, even notwithstanding the differences that you described. So, gentlemen, thank you very much. And I hope the audience have taken a lot from this very measured, very informative lectures, and to the next. Goodbye.